Good afternoon, and welcome to today's webinar titled Driving Success: How Optimization Services Foster Quality Documentation and Physician Satisfaction, presented by Healthcare Informatics. My name is Heather Landy, Associate Editor of Healthcare Informatics. Today's program is sponsored by Nuance. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, please use the Q&A area below the slides at any time. You do not have to wait until the end of the program. For technical issues, please click the Test Your Connection button below the video window to chat with support. And finally, to download a copy of today's slides, please click the link in the Resources tab to the right of your presentation window. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag #HITLiveWebinar. At this time, I would like to introduce our speaker for today's program. Dr. Stephanie Lahr is the Chief Information and Chief Medical Information Officer for Regional Health. Prior to her current role, Dr. Lahr served as Medical Director of Information Systems and Hospitalist at Kootenai Health in Coeur d'Alene, Idaho. She has also served as a physician consultant for Meditech, Cornerstone Advisors, Kalispell Medical Center, and National Surgical Hospitals. Dr. Lahr earned her medical degree from the University of Texas Medical Branch at Galveston. Thank you, Dr. Lahr, for taking the time to speak with us today. And with that, the audience is yours.
Thanks, Heather. I'm happy to be here and appreciate the introduction. Looking forward to having an interactive conversation later in the webinar and sharing with you the story where I've been with Regional Health over the last 2.5 years. It's always difficult to encapsulate in the title of a talk like this what you are really trying to get at in the body of the story. So really, I'm hoping today to take the opportunity to share how we made an EHR transition and leverage that opportunity to reinvent the tools and expectations that we had around documentation and physician support in particular, as well as some of the things we did for patient support and to improve the patient experience. So jumping right into our agenda, first thing I will do is give you a little bit of information about who we are as Regional Health, then provide a little bit more information about the EHR unification project I was just describing, go through some of the key phases, at least in the ways that those are relevant to the topics we want to cover today, some of the challenges, and then develop subsequent plans that were developed around each of those phases, looking a little bit into optimization, and then hopefully have some time at the end for questions. So Regional Health is the largest healthcare system, really the only healthcare system in Western South Dakota. We do have a variety of other independent small clinics, but the hospitals, the 5 hospitals and managed hospitals in Western South Dakota and Eastern Wyoming are associated with the Regional Health System. We have 24 clinic locations. We also have assisted living and long-term care facilities, 6 urgent cares. We really do basically everything except transplant medicine, but a lot of our care is definitely rural health. We're several hundred miles in any direction from a major metropolitan area. So several years ago, we were in a similar position probably to many, where we had accumulated, probably is the best word, a variety of technology platforms, different tools we were using. Most of them were siloed. The workflows were more reactive than proactive, and we really didn't have a strategy around how we were using technology, and therefore it really wasn't working well for us. So at the time, we had 9 different EMRs across our system. Patients could receive up to 11 different billing statements, depending on which area they were being seen. We had 5 different patient portals. So from a patient satisfaction standpoint, we were also challenged in that their data was very disparate, both in their access to it, as well as our clinical providers' ability to coordinate care. So a decision was made to transition and go through what we called our EHR unification project, where all of our clinics, hospitals, and any facility in the acute care and ambulatory environment would transition to Epic all in one big bang event, and that occurred in October of 2017, so just over a year ago. Any major EHR journey or project like this has obviously a lot of phases, and there are some key phases I want to talk about today related to the tools around how we were going to provide support and make some pretty significant changes in the flow of information. So certainly we went through a long period of direction setting, goal setting, decision making, governance creation, and then of course the build and validation of the system. But we had really three key phases that we felt like once we got to the point of turning the system on, we were going to need to progress through three phases and approach each of them a little bit differently from the standpoint of resources and tools that were going to be needed. So I'm going to spend some time talking in detail about each of these three areas, the go live, stabilization, and optimization. So the go live event I sort of define as a 30 to 90 day duration, starting probably about a month or so before our go live time period. During that time, you have a high intensity of available resources. It's usually a very expensive time period, but it's also a key time in the success of making sure that the new software, the new processes are going to be adopted. So we wanted to, get through that go live event, avoid any disruption really to care delivery, have that be as seamless for our providers and our patients who were trying to work through our system as possible. And obviously key important to any healthcare organization is we also needed to make sure we could get back to the point of getting bills in and out the door. So some pretty focused effort in that first 90 days around a go live event. Then our stabilization period really sort of went from that 60-ish days after go live until really just recently, about a month ago when we were a year post live. So during that time period, we knew that we were going to need a higher level of resources than probably would be our ongoing strategy. We needed to solidify the use of the tools that we had just rolled out. We were going to be doing modifications to the build in areas where we may not have gotten it right out of the gate. We knew we would have providers and other caregivers who needed additional training and support just because of the magnitude of the change. And so really, I think stabilization is the right term for what that period is. Then we move into optimization, and optimization is where I would consider us to be now. That really for us now focuses on, now that the system is live, is stable, our users are in general adapted to using the system. Not to say that things are perfect, but people are acclimated. Where do we really go to drive improvement in that? How do we make people more efficient? How do we get them either more time back or allow them to do more in the time that they're working? How do we evaluate additional either modules or add-on functionality that can enhance the experience because sort of our basics are wrapped under the belt? And really start to look at the ROIs that our board set out as our goals as we made this transition in our EHR unification project. So I want to break each of those down into some sub-projects and goals that were really associated with each of those timelines. All of these goals were set out at the beginning prior to our go live based on some assessments that we had done of really where we were at the time. So just to give a little bit of background, when we were live with the 9 EHRs, we had at the elbow support, so to speak, located geographically across the system. That was sort of a Monday through Friday situation. They reported a little bit through our informatics team, but also reported sort of through the operational leaders. They were embedded in those clinical areas, and we had a high degree of variability in those resources. We also had some places where one individual was supporting 150 users and another location where they were supporting 20 users, just because of the way our geography works out. Our organization, because we were going live with Epic all at one time, we had no internal knowledge or expertise in the Epic EHR at that moment. So we knew at the time we were going live, we were creating a super user program, but the reality was we were relatively sure we weren't really going to be super at the time we went live, because we were all learning the system for the very first time and didn't have the opportunity to leverage, for example, a rolling go live where we had a site go first. We learned from that experience and took those users and took them into our next phase. So we needed to come up with a strategy to support our go live, leveraging support that was already an expert in some way. We needed to transition ourselves away from the specialist model, EHR specialist model in our practices and in the hospital, where in many cases those were nurses, clinical informatics nurses in particular, but they were often being pulled in directions like refilling printer cartridges, managing the tasks of help desk tickets that were coming in on hardware, software, etc. They weren't really using their expertise and knowledge in informatics or in a specific EHR system. And it was felt that that certainly was not going to serve us well as a model during go live or beyond go live in our new environment. Our patient information obviously was disjointed and all over the map related to the 9 EHRs and patient portals that we had. So certainly that was a primary objective, was to unify all of that information, but at the same time create some rules of the road, because one of the benefits, so to speak, at least can be perceived benefits and difficult challenges in a unification like this, is that the siloed environment allows individual practices and or specialties to do things the way that they feel suits their practice and not really have a group thinking mentality about how we make it a positive workspace for everyone. The other thing that was a reality for us prior to our Epic transition was that we had pretty significant delays in our documentation. We were very heavily dependent on back-end transcription services. Even in our ambulatory environment, we had providers that were using handheld devices that they were recording information onto, docking them, and then having a transcriptionist put that information back in their notes for them. In the hospital, we had a high dependence on back-end traditional dictation for H&Ps, even progress notes, discharge summaries, surgical and operative notes. So in addition to the clinical information being spread out over multiple systems, we also had pretty significant delays that a lot of our clinic, even our emergency room documentation, because of the methods they were using, were not available for 12 hours for the ED at times, and in a lot of our clinic and hospital settings, 1 to 2 days. So any transitions of care were being challenged. So we knew that was something that had to change. So as we created our action plan specifically around Go Live, we obviously set the groundwork that we were going to all go to one unified health record across the system. We knew we were going to need a robust at the elbow support strategy, but that it had to be robust for a period of time, but then go away and transition into something else, kind of going back to that time period of, go live is something that's very expensive. You can do all of that and it's very necessary early on, but that will eventually have to evolve into something that's more maintainable over time. We decided to address our documentation issues. Our physician advisory committee decided that we could take on the challenge of doing away with traditional transcription if we could prove to our clinical providers that front-end speech was a viable solution. We did have Dragon Network Edition at the time in certain pockets. It was not well adopted and was really not even well liked at the time. We had a handful of providers that were using it very well, and a bunch of others that had either tried and stopped or didn't ever bother to try. But because we wanted our documentation to be as real time as possible, we decided we were going to make an investment in a transition to a more sophisticated, responsive front-end speech product, and prove that to our physicians before we went live with Epic, so that then at the time we sort of flipped the switch for our EHR unification, we essentially eliminated all of the use of back-end transcription with the exception of operative reports. So as far as the outcomes for Go Live, back to the topic of the support and how we were going to develop the support during that time period. The expertise was something I knew we were not going to be able to have internally. We were already in conversations with Nuance about a 24-hour call-in service for EHR kinds of questions, or a clinical help desk is what we call it. And this was part of the solution to the strategy around the solution for the EHR specialist program that we had from 8 to 5, Monday through Friday, with a varied number of skills, and trying to scale that to something with the complexity of Epic. We didn't have availability of clinical help desk support 24/7, and even our technical help desk was not open 24/7. So I initiated a conversation with Nuance about a clinical help desk in which our care providers that use the Epic system specifically would be able to call in 24 hours a day and get assistance with their questions, whether that's, documentation, flow sheets. We didn't limit it. I didn't want to limit it, whether that was nursing or providers. We even allowed our revenue cycle folks to call. Basically, anyone that was an Epic user had an opportunity to have 24-hour support. During those conversations about initiating that 24-hour support, we also began to talk about at the elbow support during this go live time period. We had started to work on our strategy for a super user program, but again realized that there was no way our super users were going to be confident and competent enough to support a go live of the magnitude that we had, since we were doing big bang across our system, since the system was going to be new to those quote unquote super users as well. So we started to develop a program around combining the 24-hour call-in service, which we would stand up on the day we went live, but also bringing in a team from Nuance to provide the at-the-elbow support for our clinical providers mostly, so our physicians and in our clinics, our front desk staff, as well as nurses and other clinical caregivers in our hospital environments. We also then turned on Dragon Medical One as our new front-end speech voice recognition program. We turned that on about 6 months before Epic with our previous EHRs. It wasn't mandatory, but it was an opportunity for us to prove to people that the technology was much better than the other the previous platform that we had been using with Dragon Medical Network Edition, and that it was a realistic possibility to be able to use that as their sole tool for voice recognition, as well as the tools that are built into Epic with Smart Text and Note Writer and those kinds of things. So we went through our go live time period, and the key element for me that demonstrated the success of having we had a little over 200 folks from Nuance here during the time of our initial go live, in addition to the 24-hour call-in service. And what that allowed us to do was keep our analysts in the command center to actually fix problems and work on build during that the 30 days that we had the command center open. I had one instance where we had an analyst leave the command center to go and provide at-the-elbow support to a particular caregiver in a specialty area. The rest of the time during that 30 days, the support at the elbow was able to be provided by the folks that we had brought in from Nuance and the small cohort of super users we had created, as well as leveraging the 24-hour call-in system. This allowed us to reduce our number of tickets much more dramatically than we thought we would be able to in that 30-day go-live time period. We tapered that service over really the course of about 60 days. In our clinics, we did keep some of those folks on after that 30 days for about another 2 to 4 weeks, depending on the clinic location. The transition for our clinics seemed to be more significant from the standpoint of their workflow adoption and changes. So essentially, with the transition of our go live, we completely reversed our methodology around documentation and set the groundwork for being able to support real-time documentation, and also were able to really give a great foundation to our caregivers and providers for the go live support that they needed so that we could move into our stabilization. So stabilization for us, we still had some, everyone loved the at-the-elbow support. They were very sad when those 200 folks sort of left and we tapered them off over the time period. And so we had to transition that into a model where our internal training team was providing at-the-elbow support when needed, obviously a much smaller team than the 200 we had here, as well as encouraging people to really hardwire the use of the 24-hour clinical help desk, because they were very used to having, quote, their person. And even though we had a lot of data to show that their person really didn't solve many of their problems, they were really more of a liaison, a go-between. There was a significant, and even to this day, we still battle with this a little bit, that attachment to that person to be their liaison, their keeper of their issues and concerns, and person who would escalate those things. So when we transitioned back to what I would call a more normal support strategy, we had to work on overcoming that. At the same time, when we had folks needing support, we needed to understand who needed what kind of support and where, so that we could take our now much smaller team and deploy them appropriately. And then, of course, we were still working on some additional build modifications. So we did promote the use of the 24-hour call-in system, and we were very successful in that, because we got to a point where we had about 1,200 calls a month. That was higher than our original intent. At the same time, we felt like it was a positive thing that we had seen robust acceptance of the clinical help desk. And in general, the feedback we were getting was that the clinical help desk knew the answers to the questions, or in the cases where they had build concerns, was doing an appropriate job of escalating those back to our internal teams to be able to address those problems. So what we worked with Nuance on during that stabilization time period was analyzing the data from the clinical help desk, as well as some of the data that we had from the EHR PEP data, and signal data from Epic around how our physicians in particular were progressing in their use of the system. And we analyzed that information, and we were able to identify frequent flyer either problems or callers. So we had a couple of physicians who, were calling 10 times more than any other physician. We were able to drill into what some of the issues were they were having and have our training team then go in, evaluate some of the data in Epic and focus that information back on being able to target that provider, set up specific time to work on improving their skill set, and not have our training team just sort of randomly rounding, hoping they would run into the right person who needed help. This was great from the standpoint that really the partnership with the clinical help desk, there was not a sense that, we needed to maintain a volume of 1,200 calls. When I said we really need our call volume to drop below this, we really partnered together to figure out how to make that happen, again, through analyzing the data, reviewing specific either key areas where we seem to get a lot of calls or key physicians that seem to be struggling and being able to target those and drive down those call volumes. We also drove a high level of satisfaction with a first call resolution rate of 90+%, which was certainly higher than our previous first call resolution rate when folks were having to call our internal, really more technically dedicated help desk, and almost all EHR-related concerns had to be escalated then to an analyst or a clinical informatics specialist. We also then were able to have pretty significant success related to the documentation, and so we'll get into a little bit of the statistics here. So for our clinical service desk, this data is just from November of this year. So you can see that there's a variety of different people calling and a variety of different things they're calling about. Again, we've never limited this Epic call-in help desk to any particular user. It is mostly clinical folks, though, that are calling, 26% physicians, 31% nursing. And sometimes what we see is that nursing is actually calling on behalf of a provider. So particularly in the clinic environment and the closeness of that relationship, the nurse might call with a physician issue and you work through it with them in combination. The things that they could be calling about are, anything from needing additional at the elbow support to having a build question. They are times they are break fixes that have to then be escalated. So wide variety there. But the consistent thing that we hear is that they quickly get the answers that they need. We did actually also work with Nuance. They had not previously done this before. We created a satisfaction call at the end of the interaction that is just a one-question survey for any caller to be able to give us some feedback on how satisfied they were with the service. And when we do have folks do that survey, it's almost always that they are satisfied or very satisfied. So again, the benefit of this was that this was the only way possible for me to be able to scale support to providing support that could be available 24/7. I could not possibly afford to have people either physically on call or on site with the level and breadth and depth of knowledge that our clinical help desk has without either burning people out or breaking the bank. It has also continued to allow our analysts to focus on the work that needs to be done in the system rather than support, and our training team to work on strategic training programs as opposed to sort of random hit and miss rounding and work with providers without a lot of information. This is just a little bit of information about our first call resolution and some of the kinds of things that I was mentioning last time. So our call volumes are down significantly. You can see over the last 3 months, our average is about 650 tickets per month from the nearly 1,200 that we had shortly after go live. So again, the collaboration over the course of the last year to really look at the calls that were coming in and figure out ways to more effectively address some of the questions that were being asked was very valuable and successful in driving down our number of calls per month. We still maintain a 90+% first call resolution, and our issues, are really training is a pretty significant proportion, and then Epic issues. The other benefit of this service through a partnership with Nuance is that this team is also very adept at troubleshooting and or supporting Dragon Medical One, our front-end speech tool. So we've had great success in being able to integrate all of those things into a one-stop shop for asking questions or getting someone to be able to provide support. During the last month, our call volumes did change a little bit. About a year to the date of our initial go live, we went live with the Epic 2018 version, so upgraded from 2017 to 2018. And to double the fun, we decided that we would also add 3 Community Connect hospitals and their associated clinics across the region on the same day. So we did see call volumes increase and definitely leveraged the clinical service desk and actually also the at the elbow support staff, which we'll talk about here shortly. So just a minute on Dragon Medical One impact. Again, we rolled Dragon Medical One out about 6 months before our go live, which was in October of 2017. Our go live was October 22nd of 2017. And our adoption of Dragon Medical One was not mandatory prior to Epic go live. However, we did require all of our physicians to go through Dragon training and personalization, which was facilitated by our partnership with the At the Elbow folks that were on site from Nuance during our physician training. And so you can see that when you move to November of 2017, we went from an average, of around 330 to 400,000 lines per month down to 30,000 in that first month. We did have a handful of providers who tried to game the system a little bit. We only had one dictation type that was available, and that was for operative reports. We had a couple people who thought maybe they could dictate an H&P or a discharge summary under the operative report type and fly under the radar. It just took a little bit of redirection for them to understand that that wasn't going to work and to go back with them and work on the other tools. And really the tools worked for them well enough that within just a couple of months of going live, we were down to 15,000 lines or less per month of traditional back-end transcription, which is exclusively in our operative reports area. So that was a huge success for us. And while it was essentially a mandate in that we said this is what was going to happen from our physician advisory committee, we really did not have any sort of upheaval or backlash from providers at the time we went live with this transition, because again, they felt the tools that they had were adequate and they saw the value themselves in having more real-time available documentation. So I want to switch gears just for a minute to talk about something else that we were working on at the same time as this before we kind of move into the optimization phase, and that's the patient-facing side. I alluded earlier in the conversation to the fact that our patients had 5 patient portals that they were interacting with. that one of the primary goals of our EHR unification was really to improve the patient experience. And by unifying the information, we knew that would improve the care they would receive, would improve their access and ease of use of the information, and allow them to really become more involved in their own healthcare and satisfied with it. So when we had 5 patient portals, we had probably 9 different ways that those patient portals were supported. There was nothing sort of streamlined or, again, no strategy around this. Our HIM department did some of it, our clinics did some of it, our physicians did some of it. In the hospitals, the floor nursing staff were doing some of it when patients would come in and out of the hospital. So we didn't have a good strategy for how we were going to support the patient side of the portal when we went live. And we knew that adoption of the patient portal by our patients early on in our transition to Epic was key to continuing to grow and continue to grow their engagement in the use of the system with us. So we didn't want them to get off to a bad start because we couldn't focus on what their needs were while we were learning a new system. So again, we really made a decision that at least initially we were going to need to have some help in providing the support for our patient portal. So again, working with Nuance in the sort of same team that we worked with for our clinical help desk, we leveraged their MyChart service desk. And the initial strategy was for a 6-month engagement to sort of get us through that initial time period when we were going live with Epic, to make sure that we could focus on learning the tools we needed to learn, and that if the patients needed help getting signed up or understanding what information was in the patient portal, that they had a good resource for that. We were very aggressive in our transition to the new unified model in making the patient portal something that really worked for the patient. We turned on as much functionality as we possibly could, including some limited scheduling, bill pay, communication, and we also decided that for the most part we were going to be sending most results real time and even some documents. So we knew they would have questions. We knew they would need support. We worked with the Nuance MyChart service desk in a 6-month pilot, and essentially had them support any of the calls that came in from a patient about how to deal with their patient portal. Certainly, there are times that people think they have a portal question that it turns into more of a clinical question or a billing question, and so we do have a way to be able to escalate those calls to the right internal team member. But this was a huge success. We had great feedback from the patients that this was a great service, that they felt worked well for them. It was very consistent across the entire system. We had an 86% first call resolution on the patient side of things. And so we really actually decided at the end of that 6-month engagement that we were going to continue to work with the MyChart service desk to provide this service, because we didn't feel as though we were going to be able to provide the level of service that they were going to be able to, and that this was an investment that was worth the continued cost of the service. So kind of where we are today and moving into the optimization stage, since as I mentioned, if you define optimization sort of as the 1 year plus, we've really just embarked on that. So as I mentioned briefly earlier, we added 3 hospitals, and two of those hospitals had clinics through Community Connect the same day we went live with the 2018 upgrade. Our teams were working on the upgrade. Our training team was working on both internal training as well as the training tracks and updated curriculum for the Community Connect sites. But once again, we were faced with a situation where we knew we didn't have the internal bandwidth nor did the critical access, all of these 3 hospitals were critical access hospitals, would have the bandwidth to be able to support a super user program for Go Live. So we, again, leveraged the combination of the 24-hour clinical help desk, which those sites now will be a part of using with us. And we brought back the at the elbow support team that had been with us during our own Go Live to support that Go Live. We continue to work on the, now that we have the speech recognition tools in place, we're starting to talk about what are the next steps of that look like. Do we want to look at more natural language understanding opportunities to assist in documentation so that providers can avoid queries on the back end? Do we need to be looking at a training sort of optimization project and revisiting how we provide physician and caregiver training and ongoing support, and what kind of additional support might we need from external partners in order to be able to do that? So every time we make one of these assessments, we really have grown to look at Nuance as a trusted partner in figuring out what these next steps are and how they might be able to help participate in either getting us through a transitional period or offering a new service or product that allows our physicians and caregivers to really be able to perform at their highest level and make the most use of the significant investment that we made in our EHR. So with that, that's sort of the end of our story today and where we've been in our transition and what the path that we've taken to address support and changes to documentation and our EHR unification. And I'd be happy to talk through any questions or other discussion points. Heather?
Thank you, Dr. Lahr, for a very informative presentation. We've already had some questions come in from the audience. However, we would also like to remind you to use the Q&A area below the slides to submit a question at any time. To download today's slides, please click the Resources tab to the right of your presentation window. So Dr. Lahr, one of the questions that we received from the audience, how did senior leadership get involved in this seismic systemic change?
So we were lucky in that at the time that this decision was being made to sort of embark on this EHR unification project, that was led by a new CEO that had just come into the organization, and he met with a variety of clinical and executive leaders from across our health system, and really they identified that one of our key areas of struggling to function as a system was because of our discoordination, our uncoordinated approach to information sharing. And so really from the very beginning, this whole concept was led and created by the clinical leadership of the organization. So we did create then a governance team that was made up of physicians and executives from across our system that met on a very frequent basis during the 18 months prior to our go live, where we sort of talked through each of these decision points. I'll admit that some of these decision points were things that we came to after sort of the initial project plan had been developed. I actually came a short time after the initial project plan had been developed. And so there were definitely some conversations that had to be held with that governance team around an expansion of scope or expanding our project budget. I will happily report that our overall budget for the project, we came in still under, even with some of the expanded scope and things that we took on. But that was really inherent to the process from the very beginning, because it was driven by requests coming from our clinical leadership and physicians saying what we have now is not sustainable.
Okay, thank you, Dr. Lar, for sharing those insights. The next question, do you continue to use Nuance for your 24/7 clinical service desk today, and is it for all clinicians?
Yes, so we continue to have the clinical service desk. It's for essentially any of our Epic users can call in. It's most commonly utilized by our clinical folks. So, physicians and nurses being primary, and then pharmacists, physical therapists, speech therapists are also folks that call in. The great thing is that at any given moment, that service desk is being manned by people with expertise in essentially all of the Epic modules. And so assistance can be provided across a very wide variety of kind of questions and clinical scenarios and job roles, and there's somebody there who can answer those questions. We did, for a brief time period when our calls were up at 1,200, and we were looking for ways to bring that number down because that really was not, it was an overly robust response. We did consider limiting to physicians only. This is another area where our partnership with Nuance was very successful. They sort of guided us to say, before we go to that point, we think that we can help drive these numbers down by digging into the calls and figuring out ways to eliminate some of the calls. Because while it's a great service to have, you also don't want your providers or caregivers spending their entire day on the phone calling 32 different times because they, really what they need is a refresher training or a couple of hours of at the elbow support. So there is such a thing as too much of a good thing, and 1,200 calls was. And so we were able to get those calls down to a number that made better sense for the number of people we were supporting without having to limit who had access to that.
Okay, great. Thanks for sharing that experience. The next question, can you expand a little bit more on how the clinical service desk team escalates issues to your internal technical team and analysts?
Absolutely. So we use a ticketing system for our help desk. And so when our providers basically call in one number for our help desk, and it's a phone tree, and so it says, if this is a concern with Epic, press 1. If this is a non-Epic issue, press 2. So if they press 1 and they get our clinical help desk, and the clinical help desk identifies that the issue is, for example, a build-related issue, not an educational item, then we've worked with them on a way to identify what of those issues are real-time, escalation hot tickets, call-outs, or pages on a 24/7 basis. And we do have a Tier 2 analyst level support that is available for backup of any of the Tier 1 clinical help desk efforts. So if the issue is considered, a build or maybe optimization request or a tweak of the system, but is not considered something to be immediately impactful, so sorry about that, immediately impactful to the workflow, then the provider is given basically the information that they'll be contacted by one of our analysts, and then the clinical help desk has access to our ticketing system, so they create a ticket on our provider's behalf, and we're able to then reach out to them directly. If it is considered to be a workflow stoppage or patient safety event, they have our escalation pathway to be able to get to an analyst or whoever our leadership is on call for escalation at that moment.
Okay, thank you, Dr. Lar. Moving on to our next question. It was obvious in one of the slides that showed types of care team roles utilizing the clinical service desk that physicians and nurses seem to be the two top groups. Can you tell me a little bit more about how this has impacted your organization's use of Epic?
Hmm. Um, I'm trying to think about exactly where to go with that question. I think the couple of things are the reality is nurses and physicians, especially in the world of Epic, really take on a lot of the responsibility of the success of the system, and their learning and adoption of the system is keenly important to the success of the overall adoption. But there's a huge learning curve for physicians and nurses because there is so much of the system riding on essentially how they manage their workflow, and how that trickles down to the rest of the system. So I think, the clinical service desk has been one of those things that we've been able to leverage to help our physicians get more comfortable and nurses more comfortable faster with the technology they're using, because they don't have to aggregate sort of a list of a bunch of questions that they might have and then hold those for a time that they run into an at-the-elbow support person or a trainer. They can call real time, and where they might have encountered that question 3 more times during the day and looked for some sort of workaround or struggled through it, they can fix the problem the first time they encounter it and not have to worry about it through the rest of the day. So I think it does make them more efficient and effective in their use of the system, and has helped to improve their adoption of the system. But the reality is the magnitude of change is very significant, and some of that is it just takes time. But I can't imagine having been through this last year without having that service desk available for those calls, particularly, when something comes up at 9 or 10 o'clock at night in the emergency department and they're needing support on, an issue real time for a patient. The idea that they would have to either, worst case scenario, wait till the next day, or even, not great scenario, but better than that, wait for an on-call analyst to give them a call back is really, not the ideal. So I think it's been very effective in helping their adoption, although it has been a transitional thing for them, like I said, to give up that idea that there needs to be a person physically there for them. I will also add to that, one of the elements that helped us cross that chasm a little bit is those folks at the clinical help desk do have access to be able to remote in to the desktop of the provider or nurse caregiver that they're working with, so that they can see the screen, help manipulate on the screen if necessary, show them where to go, that kind of thing. So that does assist in their ability to be able to quickly resolve their problems as opposed to waiting for somebody to show up in person. If that doesn't answer the question, I'm happy to take it in another direction if there's more clarification.
Okay, great insights there. Thank you, Dr. Lahr. Moving on to the next question. Looking back on how you approached Go Live on Epic with the shift to Dragon Medical One, what support did you gain from other leaders in the organization that helped you make this shift? Who were those stakeholders?
Well, I would say that the first and most important was our physician advisory committee to the EHR unification. They really, it was actually my very first physician advisory committee meeting with that team ever in the organization. I was literally meeting them for the first time, and about 20 minutes into the conversation, I said, well, what do you think about the idea of when we transition to Epic, we eliminate all back-end transcription? And I'll admit they looked at me a little bit like I was a crazy person. And then we started talking about, well, what really are the barriers to that? And as we dug down into what it would take to make it possible, I had the fortunate experience of making the transition from Network Edition to Dragon Medical One in a previous organization. So I had seen the success of the sort of night and day issues that are then immediately resolved or no longer exist in the new world. And so in being able to share that with them, they really said, if this is an organizational priority to improve the real-time availability of our documentation, then the organization is going to have to invest in what it takes to give us the right tools to do that. And Epic by itself is not that tool. And so after that, robust conversation and really strong recommendation from the Physician Advisory Committee, I took that forward to our EHR Governance Committee, which was made up of our COO and our CFO and a variety of other vice presidents and CMO and physician leaders across the organization. And they really didn't question it. It was one of those items where they said, yes, this is a priority to us. We are not making this transition to do things the same way we do them today. We really need to find a new way forward in the future, and we have to make the right investments in order to do that. And so we were able to put the information together and demonstrate that the finances were worth the investment.
Okay, thank you, Dr. Lahr. Next question. Has the unification project changed how you will evaluate new technology offerings in the future? And if so, can you provide an example?
Sure. So one thing that we sort of driving principle that we created around the time that we were going through the unification was that our primary EHR, which is now Epic, and as my experience in this recent scenario is with Epic. It's certainly not the case that this can't be done in other EHRs. That certainly it can be, but from my experience, what we decided here was that whatever that investment was going to be in our case Epic, if we were making that major shift, then if that EHR offered technology to solve a problem that we had, we were going to essentially trial that unless there were extremely driving strong reasons why their technology would not support our needs before we would look at another an outside vendor. So we really do have an Epic first sort of model now. The other thing is, as I mentioned, we had a whole bunch of different systems, not just EHRs, but bolt-on systems. And I think not uncommon to a lot of organizations, most of them were being used to about 30 to 60% of their capacity. They hadn't been really thoroughly rolled out with good change management sort of practices around them. And oftentimes there was not any strong executive or supervisory support and or oversight to ensure that really it was a tool that we needed. So we transitioned our EHR unification governance structure into a new process now that we have, which is called demand management, which actually is a request sort of review opportunity and approval opportunity for people to bring things forward from across the organization that are going to require the resources of a wide variety of areas. So it goes beyond IT. And now if you need, project management resources, if you need our enterprise intelligence resources, if you need IT resources, if you are going to be doing something that's cross-purpose and you need folks from, nursing and physicians and those kinds of areas, then we have sort of a threshold. It has to be a relatively big project, and we have definitions for what that threshold is. But now we really drive everyone to submit those ideas and requests through one place, and we use that opportunity to vet those out and or determine that we're not going to do some of them. And that is a much more structured process than we had in the past. It's not perfect by any means, but it's a vast improvement, at least for the visibility of the kinds of things that we're doing for technology or evaluating for technology than we had in the past.
Okay, thank you. Great insights. Unfortunately, that is all of the time we have for today. I would like to thank Dr. Stephanie Lahr once again for today's excellent webinar. I would also like to thank our sponsor, Nuance, for making today's program possible. Finally, I want to thank everyone in our audience for joining us. We hope you'll join us in the future for another Healthcare Informatics webinar. This concludes today's presentation.